My name is Li Zhou. Probably majority of people know my name. I've been here for 13 years. I started here 2006 after I graduated from the fellowship training in Iowa. And I moved to Appleton. So since that point, I have not stopped. So I'm the one to my major focus is deal with irregular heart rhythm. So this is kind of if you in a simple way you look at cardiology as a group, you can dissect into 3 different subspecialties. Some people say, okay, you are the electrician to deal with irregular heart rhythm, too fast, too slow, or irregular. That's the electrical part. That's my part to deal with rhythm issues. Some people to deal with the plug of the artery. That is a blockage artery. They call them a plumber that can open up the blood flow to get heart muscle perfused with the blood. And the third part, cardiology is a picture part. So the picture part, the people take a picture of your heart to look at your heart by ultrasound machine to see how strong your heartbeat is and what's your valve function, the chamber size. Or they can take a look of your nuclear stress test to see whether the blood flow into the heart muscle that is equal to all part, or some part is lack of the blood supply compared to the other side. So we call this part as the picture part. So if you simply look at cardiology as a complexity here, simple way, plumbing part, electrical part, or picture part. So my main focus is to deal with the irregular heart rhythm. Irregular heart rhythm is a rhythm disorder. Is too fast, too slow, or too irregular. So the atrial fibrillation is the irregular rhythm that the top chamber is beating too fast. So if majority patient have atrial fibrillation, you know that the heart has 4 chambers, 2 top, right, left, and 2 bottom, right and the left. So supposed to be normal rhythm will be the top chamber squeeze and the bottom chamber to follow. So top and the bottom, 1-to-1 relationship. That kind of heart beating in sync. That's how the normal physiology is. But when the heart is out of rhythm, meaning that they are in the atrial fibrillation. When they're in the atrial fibrillation, the top chamber is not beating regularly. It's super fast. It's beating average about 350 to 500 beats per minute. That's a super fast. Nobody can tolerate that heart rate. So the only good news is only happen in the top chamber. And the majority electrical impulse that coming down the bottom chamber is blocked out in the middle part. So the middle part, the bottom part is not stressed out. So bottom part is typically happen 110, 170 beats per minute. So during atrial fibrillation. So that is the atrial fibrillation. The top chamber is beating fast, irregular, and the bottom chamber to follow fast and irregular rhythm. So this is called atrial fibrillation. So how many types of atrial fibrillation that we have? Well, depends on how do you look at atrial fibrillation. If you look at the duration of atrial fibrillation, well, you can divide atrial fibrillation as occasional atrial fibrillation. That means AFib on and off, come and go. That sometimes lasts for a few minutes, sometimes lasts for a few hours or a few days. Or some people just have a constant atrial fibrillation that lasts non-stop, continuously, for weeks, for months, or even for years. So we divide atrial fibrillation with different categories, either intermittent or we call it paroxysmal atrial fibrillation, or persistent atrial fibrillation. So-called persistent atrial fibrillation is AFib keep going non-stop for longer than a week. That's called persistent. But if the AFib keep going longer than that, longer than a year, we call it long-lasting atrial fibrillation, or people say chronic atrial fibrillation. That's kind of, we look at the duration. But if you look at symptoms, well, if you look at symptoms, that can divide it into silent atrial fibrillation or asymptomatic. They don't have symptoms. Even though the heart is beating irregular, fast, but they don't feel bothered. I don't feel difference between the normal rhythm and the atrial fibrillation. So I can do the things I want to do. I need to do. There's no difference. I have no limitation. That's called silent or asymptomatic atrial fibrillation. Well, some people become symptomatic. Say my heart is fluttering. I have a flop in my chest that kind of going whack. Especially in the nighttime, bedtime, you notice more. Or some people more feel like, I don't feel the flop in my heart, but I can feel my strength, my endurance, my stamina changed. I cannot do as much I can in used to be. Especially when they climb stairs, or especially when they go incline, that they have to stop in between to catch up breath. That's the most common symptoms of atrial fibrillation. Or some people just have a short-winded. I cannot take a deep breath in my lung. I kind of shallow breathing. Or some people just feel sweaty. That is kind of symptoms of atrial fibrillation. Now, people don't regularly check the pulse to see what their pulse is. If you learn how to check a pulse, hey, when I have a symptoms, I will check my pulse. Is it regular or is it irregular? Is it even or uneven? Is it fast or is it slow? So you can tell by checking your pulse if your heart out of rhythm or in rhythm. That is the atrial fibrillation symptoms. So you can divide asymptomatic or symptomatic. In terms of the severity, there's no difference between asymptomatic and symptomatic. They can do the same harm to your body. So don't just look down, oh, I don't feel difference, I can ignore that. You should not ignore that. We talk about how serious of atrial fibrillation. Now, atrial fibrillation by itself is not life-threatening. Some people, you feel weird or my heart beating irregular. Some people feel threatening of this. But by itself, AFib is never to be life-threatening situation. But two things, three things maybe you should keep in mind that can do some damage to us. What? Number one, biggest danger is the stroke. Stroke is the one that if atrial fibrillation population, they can cause stroke 5 to 7 more likely cause atrial stroke than general population. If the atrial fibrillation not treated, 1/3 of the patient will end up having stroke. So that's serious. So the atrial fibrillation stroke is more harming and more disabling compared to non-AFib stroke. Why? Because think about it, when atrial fibrillation is happening, when AFib happening, the blood flow becomes turbulent and the top chamber is not squeezed, pushing the blood flow. Guess what? The blood is pouring in the top chamber, static. When that static creates an environment, have a blood clot build up in the top chamber, especially we call it appendage, where you have a pouch coming out of the left top chamber. That's where the most common place that forming blood clot, 90 to 95% time. So when you have that blood clot build up there, then at the time, if somebody gets shocked or if the blood clot dislodged from the pouch, guess what? They follow the blood flow, travel here. Travel here, the blood clot is a big chunk of blood clot. They plug up in the big artery of the brain. Guess what? It causes more widespread damage of the brain tissue compared to non-AFib stroke. That's a small vessel, less damage. So statistically, half people have an AFib stroke will end up with disabling symptoms. Disabled. That means neurological damage. Neurological damage. So that's serious. So if somebody has atrial fibrillation, should be evaluated, see for blood thinner. So what kind of option here? We talk about treatment, blood thinner. Well, the blood thinner include old-fashioned warfarin. Lots of people heard about warfarin is RAC point, right? So you use that to treat RAC. But that is old-fashioned drug, which is very, very effective to lower the risk of stroke. It's not 100%. It's not 100%. Some people still have a stroke even though they are on blood thinner. It's statistically about 60–70% reduction of the stroke risk, but still is better than nothing. So the problem of warfarin is the drug that's not predictable. It's not predictable. It's a lot of interaction with different kind of drug, the other kind of drug, or different type of food. So basically, it's a vitamin K antagonist. So work against the vitamin K. So what vitamin K to do with blood factor? Because lots of clotting factor is relying on vitamin K to build, to produce, so that work in the bloodstream to clot, make a clot. But warfarin just block off the vitamin K, so the liver cannot make enough blood clotting factor. So that is thin the blood to prevent blood clot. So therefore prevent stroke. Now over the past several years, the new medication come on board in the market. So you may heard some different name of the drug, but I'm not going to name it. I'm not a salesman for the drug. So you may heard about it. You may see the TV about it. Now this new drug is more kind of easy to use. You don't have to check the blood count. It's not variable in terms of effect that change with the different diet or different other drug. So they take either once a day or twice a day. The effect of drug is better or at least not worse than the warfarin. So the study have shown that the newer version of the blood thinner, newer generation of blood thinner have a less risk of bleeding inside the head, and is more effective to prevent embolic stroke. But some people report have more bleeding from the gut, the bowel system, but not major. So this is kind of the drug option to prevent blood clot, to prevent a stroke. Now, the newer technology also developed over the past year or so. They call it a medical device. The medical device that you put basically, you put a device in the heart, specifically in the appendage. We talk about appendage, that's where 90 to 95% of the time the blood clot build up in the appendage. So you use a medical device to seal off this appendage, basically to cut off this appendage, the communication between the appendage and the rest of the heart. So even though you build a blood clot there, it's not coming out of the appendage. Basically, you put a puppy in the kennel so that will not get out, so not go into the bloodstream to go into your head to cause stroke. So that's called device, is an appendage closure device. Have different version about it. So that is on the market right now. Our group is get ready to start, but have not really started yet. This is available in big center right now. So if somebody have a risk of stroke, but also have a risk of bleeding if you take a blood thinner, so this is the type of device you should look into. Say whether we can take a device so can avoid the risk of stroke and at the same time minimize my risk of bleeding if I take a blood thinner. So that's kind of option for the people. So this is talk about the stroke risk, and we deal with stroke. What about the other condition that AFib can do some damage to our body? We talk about stroke, and also the other thing is congestive heart failure. So why is that? Now remember that when the heart is out of rhythm, the top chamber beating super fast, but bottom chamber to beat follow, not as fast as top chamber, but still beating at a 110, 120, or 130, 140 beats per minute. But if you say, hey, I didn't know that, I cannot find it, so my heart just beating fast, unnoticed. So guess what? The heart get tired beating that fast. Not supposed to be that way. Just like somebody running marathon, you don't have the finish line. You just keep running, keep running, keep running. Guess what? You collapse. Same as your heart. When the heart is beating that fast for weeks, for months, unnoticed, guess what? Heart get tired. When they get tired, they become weak. When they become weak, they cannot push the circulation as effective as normal. So the fluid will build up in the lung, the fluid will build up in the leg, so you get swollen. You get a build up fluid in the lung, so you cannot breathe. End up in emergency room, then EKG show what? Show AFib with rapid ventricular response. So that's typical story for some people have AFib without symptom, silent AFib. So it's average about a quarter to 50% of patients, if AFib with rapid ventricular response without treatment, they end up have congestive heart failure. So those type of things, once we correct the rhythm and the heart recover, beating normal rhythm, over time, that will recover in function as well. So the strength will come back. But we do not want this to happen again and again repetitively. If that happens again, the heart said, I've been insulted many times, I'm just quitting. So the heart is less likely to recover from the weakness. So the AFib also is a progressive disease. So that means the AFib is not just occasional AFib all the time. They will progress from occasional atrial fibrillation to become more and more persistent atrial fibrillation. Why is that? Well, just like any disease entity, when somebody have a kidney problem, when somebody have a COPD, when somebody have a cancer, when somebody have a diabetes, as disease progress, the disease getting more and more serious. So when AFib started here, the top chamber doing this, almost always initially it's intermittent, then stop on its own. But as time goes by, they're getting longer duration. Guess what? The chamber will get enlarged. Top chamber, just like we talk about the bottom chamber get congested, top chamber also get tired. When top chamber get tired, they change the structure from normal size becomes stretched out. We call this called remodeling. What is remodeling? From electrical normal pace to atrial fibrillation, then the structural remodeling. Because when top chamber doing this all the time, they stretch out, have a scar tissue, the fibrosis built into the muscle layer. So the heart is stretch out. The longer you have AFib, the bigger the size is. And when the top chamber getting too big, they're more likely to stay out of rhythm. So that's catch-22. We call it AFib begets AFib. Meaning that you have an AFib, the more AFib, get more chamber enlarged. More chamber enlarged, get more likely to have AFib. So that's kind of catch-22. So those studies show that 5,000 patients, new discovery of AFib. We call it new onset atrial fibrillation. Within a year, 50% of patients will change from occasional to persistent atrial fibrillation. You can see that how progress that is, the fast progress. So we should be kind of knowing how do we deal with AFib, even though it's not life-threatening situation, but can do some damage to our heart, either stroke or congestive heart failure. If we untreated, will progress from intermittent to persistent atrial fibrillation. And then some people say, so what? I just live with it because I don't feel bad about it. Yeah, you can live with it as long as your heart is not stressed out. As long as you take a blood thinner to minimize the risk of stroke, people can live with it. For those people with silent AFib without symptoms. So how do I get atrial fibrillation? Nothing you can do about it. You don't cause AFib by yourself. And you do something wrong that bring the AFib by itself. But AFib is a condition that has several contributing factors. You can dissect into the heart problem. You can dissect the problem outside the heart. For example, if somebody have a congestive heart failure from other condition, say I have a heart attack, my heart muscle damage, so my heart is weak. As a result, chamber get dilated. And when chamber dilated, stretch out. The stretching effect can cause atrial fibrillation. Or some people have untreated high blood pressure for a long time. Untreated high blood pressure. So the heart is working very hard to push the circulation against high resistant chamber because of pressure here. So heart is working heavy loaded for a long time. That can cause atrial fibrillation. Or some people have an open heart surgery, bypass surgery, valve replacement. When they have an open heart surgery, guess what? Scar, inflammation. That can cause atrial fibrillation. It's happened 40% of patients open heart surgery. So that's the heart condition that can cause atrial fibrillation. Well, something outside the heart can also cause atrial fibrillation. For example, somebody have a thyroid problem. Super high function of thyroid. Release extra thyroid hormone into the circulation. That thyroid hormone can overstimulate our heart to get the heart out of rhythm. So the treatment for that is different from treatment for the AFib itself. You treat this cause. Treat thyroid, that can correct rhythm by itself. Or some people have a COPD emphysema, long-time COPD emphysema. Guess what? You just have atrial fibrillation as a complication from that. Or some people have a diabetes. Diabetes is one can cause atrial fibrillation, long-term wise. Or some people heavy weighted or obesity can cause atrial fibrillation. How about somebody have a sleep apnea? How about some people have a sleep apnea? Sleep apnea is one common cause of atrial fibrillation. It is estimated 18 million Americans have a sleep apnea. A lot of people sleep apnea. And it's estimated about 4% of middle-aged men and 2% of middle-aged women have sleep apnea. So why sleep apnea have atrial fibrillation? Now, the sleep apnea, you know what is sleep apnea? Sleep apnea is when you close up your airway when you sleep, right? Because your tongue fall back, block your airway. When the airway block, you get a pause of breathing. Guess what? Your body is stressed. Your body is stressed because of lack of oxygen. Somebody wants to join the show, right? It's upstairs or downstairs? Oh, thank you very much. Thank you, Josh. I cannot speak tomorrow. So when the body temporarily cut off the oxygen because of sleep apnea, guess what? It's a stress. It's a big stress to your body. So your body just released adrenaline to fight with the stress. So guess what adrenaline do to your heart? Overstimulate your heart. So that's happened many times, 30, 50 times stop breathing at nighttime. Your body just overnight just constant fight with adrenaline. That over time overstimulate your heart to get your heart out of rhythm. That's sleep apnea. So the best treatment for that condition is get evaluation for sleep apnea and treat it so that you can relieve that stress so the heart is healthily involved. And the next is the aging process. Unfortunately, nobody can correct that, right? It's aging. So AFib is age-related arrhythmias. Unfortunately, it's more prevalent when we're getting older. So it is, you can say this, is estimated about doubling every decade. So let's say 2 to 4% at age 60s, then 5 to 6% age 70s, then 8 to 9% age 80s. You can estimate that. Just every decade, the prevalence increase double. So we cannot correct that, isn't it? So that's the aging process, atrial fibrillation. What about the genetics? Some people say, hey, I'm only 18-year-old. I'm only 40-year-old. I have atrial fibrillation. It's very unusual. Why is that? Well, some people say some genetic influence cause atrial fibrillation. If your first relative, say my dad have AFib, or my brother have AFib, myself have a 40% increased risk of atrial fibrillation. That's a genetic testing.
Slow pulse rate that you should be concerned.
I see. So it is uncommon to have a slow pulse rate when you're in atrial fibrillation. You know that the top chamber is beating 350 to 500 per minute. That's very rapid. Just like the bunny. That heart is beating that fast. Typically, the cable, electrical cable, will send a signal to the bottom chamber in a faster fashion. That's typical when you have a healthy electrical cable system. Now, when your heart beating strangely slow when you're out of rhythm, you have to think about, oh, my cable system is not conduct signal in a rapid fashion. Is my cable system not good enough? Cannot conduct signal rapidly. Or maybe I'm on medication that slow my heart rate too slow. Some medication specifically slow the heart rate, like common medication metoprolol, that slow the heart rate down. So am I on too much medication? Now, what is too slow is not depends on the number. Well, number relevant. Say if your heart beating 30 beats per minute is too slow. But major is depends on how do I feel when I have heart beating slow. if my heart rate 45, 46, I feel fine. I can climb stairs without stopping. That's the right number for you. So does individual have a different number? So I cannot give you a specific number, it's too slow, but I'm saying in general, 35 below or 40 below is kind of low number. Even though you have no symptoms, that should be evaluated because it's abnormally slow. All right?
Is shortness of the breath because it's too slow? 'Cause you can't
Could it
keep
be?
breath?
Could it be slow? It's too slow from a short breath. But when the heart is not beating too slow, you might still have a short breath. Because why? Because the top and the bottom, they are not talking to each other. They are beating separately. They are beating separately. Normally, you have a connection between the top and the bottom. 1-to-1, they work together. But when the top chamber doing this stuff, the bottom chamber just confused, beating irregularly. Even though your heart is in the normal range, the rate is normal range, say 60 to 90, the normal range, people still feel short. Yes?
Is there an age restriction on a person on when you would perform the ablation procedure?
What's the contraindication? Meaning that some people cannot do the ablation, right?
I mean, if you were 75 or 80 and met the requirements, would you still do ablation in terms of the condition of your heart?
The condition of the heart, depends on the condition of heart. You're good question. So for ablation, the success rate is different. For persistent atrial fibrillation, meaning that you auto rhythm all the time, non-stop, for weeks, month, or even year, that success rate is much lower compared to somebody occasionally. Say, I have AFib for a few hours, then back to normal rhythm. Stop by itself, not shock. So that we call it intermittent atrial fibrillation or paroxysmal AFib. The success rate is much higher in that population.
So as long as your heart would be in condition, regardless of your age, you would perform the procedure?
Well, you have to use common sense though. In 85's heart is not same as 65's heart, right? 65 heart have a more endurance, right? So stronger, recover quicker. So 85 is a little too much. I used to do the ablation below 75. This is my personal cutoff. And one time I went to a conference and a doctor from outside, I believe he's from Michigan or somewhere, he said, I don't have a limit of cutoff. And the audience asked him, what's your oldest patient that you did the ablation? He said 85. And what is the outcome of ablation? Well, she did it very well. Her heart is in normal rhythm, but she suffered a stroke. So that is the concern about the risk of complication when we get into it.
So just one more question. If you wanted to continue being an athlete, per se, if you get ablation, does that correct it? Are you good to go forever then?
So,
Or not forever?
to I guess I'll put your question in a different way. If I corrected the atrial fibrillation with catheter ablation, how long that would stay in normal rhythm? Is that what you asked?
Yeah, or you could continue to do the exercise.
Oh, I see what you're
routines
saying.
If you wanted to do, are you fixed once you have ablation, and you don't have to worry because of exercise or because of running a marathon about going back into it again?
That depends on your passion. See, I like a beer, right? I know beer will hurt me, right? But I still drink a beer, right? So that's just like your passion. So we say, gee, the exercise is my passion. I cannot give it up. I'll do it. So I said, well, gee, I just push it. I try to do the best. I can control my AFib. In the meantime, I enjoy my passion. Or on the other hand side, well, I know my heart can have a risk of atrial fibrillation with strenuous activity. I maybe moderate a little bit, and do the ablation, so that reduce risk of recurrence. I'm not saying the exercise is not good. Don't get me wrong. Exercise is a good thing.
My question was kind of, if you have the ablation, then do you not have to worry about that anymore?
Well, I always worry, but you can do whatever you want. So yes, I do not want you to stop the exercise. I still want to encourage you to do what you think the best for you. But I can do what I can offer to you to fix that atrial fibrillation so that you can enjoy what is more important to you.
What is moderate exercise?
So what is moderate exercise? Good question. So what is moderate exercise? So a simple way to measure the moderate exercise is that you do your, say, on treadmill. Some people have a different tolerance. I can say I run slow pace, I run fast pace. Everybody have different. So to you, so that you walk fast or long enough so you cannot complete conversation or continue conversation with the person next to you. So some people just run fast without talking, so they can run fast. But if that person have a conversation with the person next to you, say, I short-winded, I cannot continue the conversation, that's moderate exercise. So to a point that you cannot commit conversation, that's the moderate exercise.
Length of time?
Length of time, you can do, just say, the American Heart Association recommend 5 days a week, 30 minutes a day exercise, moderate exercise. That's good. So I still encourage the exercise. It's a good thing. But I'm just saying there is an experience from medical community that over-exercising, athletic population, have a risk of atrial fibrillation. That's the fact. I'm not fabricating this. This is a fact. I'm not against people have a passion about exercise. Next question.
You know when you were talking about that procedure where you, the appendage or where
Yes.
the blood pools, why wouldn't you have that done so you know that there isn't going to be a blood clot going to your brain?
Why would not done this? So this is the procedure not having, it's just recently developed, number one. And number two, this is not risk-free procedure. Have a risk, just like a medication, you have a side effect risk. This is also risk of the perforation of the heart. You mean you put a device in the heart, and basically there's a kind of several legs of this device kind of hook in your heart muscle, and just make sure it's not mobilizing. So when this leg hook on your heart muscle, if it's too strong hook, guess what? It causes bleeding around the heart. Or some people say this device is not hooked enough. They migrate away. Migrate away then to different part of the heart, damage the heart. So this is not risk-free. At least the guideline right now say you have to think about the medication first. If you're not suitable for medication, then you try to consider this device to help you. Either you have a high risk of bleeding, that you cannot take blood thinner. At the same time, you have a high risk of stroke. So you're stuck, then you consider this device.
So if I'm on medication that's controlling it,
Yes.
stay with.
Yes, they are warfarin. But some people argue that, well, medication often have a risk of stroke. Well, what if I got a car accident? What if I injure myself and I might not stop bleeding? That's a risk, right? So if you try the drug and you say, gee, I really don't like the drug, I cannot tolerate the drug, then you can make an argument, have a device put in. Yeah. Any other question? Yes.
So my internist determines I have an irregular heart rate, or say my general cardiologist does.
Yes.
When and how do I come to see you?
Come to see me? You know my name here, right? So you just come to the front desk here.
I can just self-refer and then.
Yeah, you can do that. You know, our door is open. And by the way, we take lots of insurance. Some people just say, oh, you don't have insurance coverage. Well, we just signed up for Blue Cross Blue Shield, Anthem. And we also signed up for United Health. We also signed up for the other insurance company, and lots on the way. We just opened up the business for 6 weeks, right? Think about the progress we've made. Well, we all started from fresh new to talk about the insurance company get a coverage. Some insurance kind of slow process, so we cannot control that. So we have to wait their pace. So we already get a majority insurance coverage. So we should be able to see the patient. That's not a barrier for you to see us. Anybody have any questions? Yes, okay.
What's the best outcomes, rate versus rhythm type of program?
So the question is, the question is, what's the difference between rate versus rhythm control? So as I said before, there's two ways to manage it. One is to live with it. You're out of rhythm, but your heart is not stressed. You take a blood thinner. You just live with it. The other approach is to fight to normal rhythm. Fight for normal rhythm. You take cardioversion, you take a medication, strong medicine to keep my heart in rhythm. At the same time, you continue the blood thinner. So what's the difference between two groups? Number one, there's no survival benefit. No survival benefit to live in the rhythm control group. The survival is the same between the two groups. That study has shown many years ago. Why is that? We know the AFib is not a good thing, but why we keep the heart in normal rhythm still have no survival benefit? The reason for that is the side effect of medication bring down the benefit of, negate the benefit of normal rhythm. So does that answer your question?
Yeah, I have one more.
Yeah.
Beta blockers versus ablation. What kind of outcomes are there?
The beta block and the ablation is not countering itself. We often use beta block even after cardioversion or ablation or before the ablation. Beta block is the drug that tries to slow down your heart rate to make your heart is not stressed during atrial fibrillation. That is the medication we commonly use. The drug itself is pretty safe drug to use, unless you have asthma, unless you have a severe depression, then you don't use the drug. But most people use drug for different reasons. Somebody have a heart attack, some people have a congestive heart failure. They all use drug in addition to the arrhythmias. So we use beta block combined with all different conditions, also include catheter ablation. So it's different thing. So the ablation, we have to look at the patient condition to see if your candidate are not worth it because of risk there.
So if you do an ablation, you're probably going to get beta blockers with that to maintain it? Or not?
We don't have to use beta block to maintain it. Beta block is not to maintain it. Beta block is control your heartbeat to make sure it's not too fast. Yeah. Next question.
Doctor,
Hey, Marty.
are there any adverse long-term effects of taking metoprolol and flecainide?
Flecainide is the drug, is a rhythm medication. We normally do not use it unless we have to. So the drug is to maintain a normal rhythm. This drug only used for patients with normal heart. But if the patient have an abnormal heart, meaning that they have a heart attack, meaning that they have a blockage artery in the heart, meaning that they have a congestive heart failure, or meaning that you have a thick heart muscle, too thick, then the drug is not safe, not worth it. It will do more harm than good. So do not use this drug unless your heart is healthy and good. So the metoprolol is different. Metoprolol is a very safe drug to use. My mentor used to say you should put metoprolol to tap water so everybody can drink it. So that's a health heart condition. It's going to relax your heart. What does metoprolol do to your heart? It's a beta blocker. What does beta blocker do? To block off the adrenaline. You know the adrenaline is stimulate your heart to get your heart excited, beating fast, or out of rhythm. So the metoprolol is put a shield around your heart to block off this adrenaline attack, to put your heart relaxed and in a stress-free environment. So that's the metoprolol job.
But do they affect any other organs?
No, it does not, unless you have asthma.
Oh, sorry,
All right.
no time.
Yes.
I filled out the paperwork with your name on it.
What?
I filled out the paperwork with your name.
Uh-huh.
If I have to go to emergency, do I ask for you or
Oh, I see what you're saying. Now,
how do we go back to A?
I know you ask a sensitive question here. I should be politically correct so that people would not go after me. So we'll walk away from theater care. So we become independent. it's not easy journey. I tell you, it's not easy journey. And lots of stress. But I think it's best for our patient. We have our own right to make the best for the patient. There's a reason we left theater care. Because we feel our hand tied to treat the patient. They drive you differently for different purpose. Some people say money driven. So anyway, we come here to be independent so we can see the patient to do the best for the patient instead of money. So we make agreement with the hospital when some people end up in emergency room. You said, okay, my heart doctor is so and so, and I want that doctor to continue to be my heart doctor. So they have to observe your will, your wish. They cannot violate your wish. They cannot assign you a different doctor. They might sell you a different doctor, say, okay, I know your heart doctor is here, but I have a different doctor that can treat you faster, give you a fast track. That's baloney. So there's no fast track. Be honest with you, we are available 24/7. Our doctor is always on board, on call, every day, including weekend. So they are not faster than us. Basically, they don't have electrophysiology themselves. Oftentimes, they see the patient and refer to me anyway. So when you say my doctor is so and so, I want that doctor to be my car doctor, they should observe you, your wish.
Doctor?
Yes.
My wife is on 3 different drugs for AFib. Maltac, Eliquis, and metoprolol. What would the reason be for all 3 of these?
So 3 different drugs have 3 different purposes. The Eliquis is the blood thinner that keeps your blood thinning from having stroke. The Maltac is a drug we call the rhythm medication. The rhythm medication is trying to keep your heart in rhythm as much as possible. Have nothing to do with stroke prevention. That's the rhythm medication. Now the metoprolol is a backup in case you're out of rhythm. In case your heart out of rhythm, guess what? Your bottom chamber is going fast. So to prevent stress to the bottom chamber, you use metoprolol to relax your heart when you're out of rhythm. So different drugs have different purposes. Yeah. By the way, the Maltac, I stopped using the Maltac.
Did you?
Yeah.
Because?
Because it's not working to a majority of patients. So, back to 5-6 years ago, when a drug company sell the drug to me, I used it for a bunch of patients. But they all come back, heart is out of rhythm. And the shop out of rhythm again. I said, this is not the right drug for my patient. So I stopped using that many years ago. Maybe if you have a better luck for your wife, maybe it's good for
I
her.
think we need to ask our cardiologist. Thank you.
Yeah, sure. But I'm not, don't tell you what I say this, otherwise I'll be in trouble. I'll stay on somebody's toe. I don't want to say that. I will be correct politically.
What is the difference between AFib and then something called A-flutter?
That's a good question. What is flutter? So basically, from patient perspective, the fib and the flutter will do the same thing. The risk of stroke, the risk of congestive heart failure. They are the same, but the difference is mechanism. The difference is mechanism. In a simple word, the atrial flutter is one short circuit, electrical short circuit in the heart. One short circuit. So that the waveform of this signal is regular. It's the same shape and the same interval between each waveform. That means one short circuit. Versus the atrial fibrillation, have a multiple short circuit in the top chamber. So they move randomly, they move continuously, give you very much irregular signal. But the treatment also different. If somebody have atrial flutter, then ablation for certain type of flutter, we call it typical flutter, have a very, very high success rate. That's the #1 choice for ablation for atrial flutter. Ablation for certain type of flutter is #1 choice. I said again, why? Because drug will never take a flutter away unless suppress it. But ablation can cure the flutter, certain type of flutter, with
So
95%.
ablation does not cure AFib, though.
What?
ablation does not cure AFib.
Yeah, so
You
far
go-
we
you're
cannot
back in the
claim that
rhythm.
cure. It's not claiming cure. But I say the blood ablation can be cured. Why? Because the success rate is 95% or above. And much lower risk of complication. So you can, some people stop the blood thinner afterwards because we are so confident that you'll stay in rhythm.
Do you do procedures like the cardioversion on site here?
Yes, we do. We have anesthesiology come over here once a week, or maybe in the future more than once a week. So we will do the cardioversion here for patient convenience.
When
Yeah.
are you starting the surgery center?
When do we start the surgery center? Okay, so you have to see the baby. When the baby learn to standing first, right? Before walking, right? So we have to see this infant going to survive first. The money is an issue. You know, the surgery center is a very much cost, and we want to make sure ourselves survival in terms of we have lots of pressure. You know that, right? So lots of pressure, not from here inside, also from the hospital we used to be an employer. So give us lots of headache. So we want to survive first. Yes?
Should we switch from Theta Care to St. Elizabeth?
Oh, that's a good question. So we don't know that yet. So I think you should switch from Theta Care to here first. Right?
You just say I have a heart attack, I gotta go to the hospital.
Oh, that's a good question. We are working with Ascension now, the Ascension to have a privilege or credential to be able to see the patient over there. Right now, we are in the process of that. So give us a couple more weeks, a few more weeks to get that credential going, so we can officially see the patient. All right. So right now, we are in the process.
Not all physicians
Huh?
here, not all physicians here are staff privileges of the Ascension?
Nobody yet. We all applied the credentialing there. We all applied the privilege there. But they are the big organization. They move step slow. I'm not blaming them. They have a lot of layers to go by. So just give you example. So to apply for credentialing, they have you submit certain document. And one document is have your mentor in your training program to write letter to support that you can do certain things. But my colleague who has been in practice for 27 years here, he said, my mentor already on the ground. Right? Can you just wake him up to write letter for you? So it's not possible. So this just some common sense here. So they have to overcome that kind of the written law rule.
Getting back to the question of requesting you in a hospital.
Yes.
It's our understanding from experience going to St. E's, that, you know, you go through the emergency routine and they finally decide there's enough testing required, they check you into a room, and then you're at the mercy of somebody called a hospitalist.
Yeah.
We haven't cracked the system of knowing how to get our family doctor or a specialist into a hospital in this area, if you feel more comfortable going that route.
So if you say end up in Mercy Hospital in Oshkosh, right?
No, I'm counting the ones here.
St. E's,
We're
okay.
from Oshkosh, use Oshkosh.
Okay. St. E's, right? So we try to get a privilege in the hospital so we can go there to see patient over there. So right now it's a process. We have not get official okay to see the patient over there yet, but eventually we will.
But do you think you'll be able to crack the system where they operate with hospitalists and?
So that depends on the collaboration. I think eventually, yes, when they need a heart specialist, said if you end up in emergency room, you got admitted to the Ascension Hospital, and the hospitalist taking care of you. But if you have a heart rhythm issues or any heart issues, valve issues, the congestive heart issues, or the blockage artery issues, you say, hey, can I have a heart specialist from Heart Vascular Institute here? Then they will show me to respect your wish, right? Say, okay, we'll get doctor to see you. Should be able to, if you insist.
Where do you have privileges now?
Theater care, still there. Theater care included theater clock. Now they call it theater care Nina, or theater care Appleton. It used to be Appleton Medical Center. And I have a privilege in other outside the hospital, but never used. For example, Shannon, Wapaka, Ripon, but haven't gone there.
What about Oshkosh patients?
Oshkosh, I do not, Aurora, Oshkosh, Mercy, I don't have the privilege there yet. But once we get privilege from Ascension, then she'll be able to go to Mercy. But Aurora, I don't have the privilege. But maybe something new, you never know. Stay tuned. Yes?
If you're traveling out of state and you have a problem, say a heart problem, how do you, does the hospital or the doctors have access to it?
That's the question, repeated question. If somebody travel outside the state, say California, and then you end up in the emergency room with heart issues. Now, how can a doctor over there to get medical record from us? Now, when we were in theater care, we have a so-called EPIC system, the electromedical record system. You know, the EPIC is the pretty much dominant medical record system across country. So majority hospital, they use EPIC. So the EPIC have this called EPIC everywhere, so you can access the medical record from outside the state. But since we left the theater care, they cut us off the EPIC use. So even if we beg them to use it, we pay the money to use it, they won't let us to use it. So then we just use a new different system called a GEMS system right now. So when we use this system, they will not allow us to communicate with EPIC. So then the trouble is we have to go back to old-fashioned, meaning that telephone call, have your California emergency room doctor call your doctor here, and have your nurse here to send a fax your medical record to the doctor over there. Say this is the hard copy of that. So right now we go back to the old-fashioned, but eventually, once we come back to the EPIC system, either different way, some way, then we should be able to communicate.
I don't understand why they should block your use of EPIC.
Ask them, right? Ask them. You know, seriously, I have same question. Why not? For patient care.
Very upsetting.
Right, so patient care. If you have a question, write a letter to the newspaper. You know, just say, why? Why write a letter to the board of directors of theater care? Why not let doctor to communicate with different hospitals? They cut off the nurse to use the EPIC system. So when the nurse get a phone call from one of you saying, I get a heart problem, so how do I deal with heart problem? The nurse have to see, what's your problem first, right? Have to go back to your medical record to see what is your problem, to be able to answer your question. Right now, the nurse have no access to EPIC. So have no way to answer, have to jump the loop, go around to find what's your medical history, to call you back. That's the frustration from patient, that's the frustration from us too. Yes?
A number of us who've been here a while have a long-term relationship with our physician at Theta Care.
Yes.
And also a cardiologist here.
Yes.
So my records, for example, are at Theta Care in EPIC.
Yes.
But then I pulled all the stuff off and gave it to Doug so he would have access to it. But I think the question here is trying to get care without going over this brick wall. And I hope that works out.
You know, you have a good relationship with your theater care family doctor. We have a good relationship with the family doctor there too.
Yeah.
They have the same frustration as you do and as we do.
Yeah.
So they said, why you not just communicate with us? My patient see you for special care. I want to see the outcome. I want to see what's the plan. They cannot see that. So right now, we just use old way to send the fax to their office. And the computer just scan the record to the computer, just like memory stick, not real computer. So that's the frustration we have. But we still want to communicate with the family doctor to let know what happened here. We do the best we can, but just longer time. Yes, what's your question?
Forms that we filled out to have our medical records sent to you, from there, you have here? Because we had to fill out forms to transfer our records here.
So transfer the record here, it is the consent form, but does not automatically come to here. So we have to make a phone call to their medical record saying, we have a patient request to send a medical record here. Then show them you have a consent. Then they will send record here. It's lots of process. It's not automatic. Wish it could be automatic. So the question behind.
Do you do procedures here in this building? Like,
To-
do you do the ablation, do you do a cardioversion? Or
We do cardioversion here, yes.
Okay.
We do TEE here.
Okay.
So what is TEE?
So where do you go if your patient needs ablation?
Oh, right now, Appleton Medical Center.
Okay, that's
So
what I wondered.
that's right. So
Okay.
I still do that ablation once or twice a week
Okay,
at Appleton Medical Center because we have equipment there,
right,
because we have staff there.
okay. So I just wanted
So
to-
right now, answer your question, the surgical center, ambulatory surgical center, that's a future direction, but I don't know how long it'll happen, how long it'll wait.
Right.
So right now, we're still going to the hospital now.
Okay, okay.
So are you saying that since we sent from your website, you gave us this sheet?
Yes.
That the records transferred?
Yeah.
Now they're not transferred?
Some record transferred, but they have to take the action to get the record transferred. If you send, say, consent form,
Yes.
that's just consent. It's not action yet. So we have to take action to call the medical record, say, we got a consent form. The patient want to transfer medical record to our institute. So we have to call them to put in action.
You do the calling. We give you this consent form and then you do the calling?
We have many, many of your medical records here. When you sign those releases, they are here on a server. We're able to see them, but they're not integrated into our full charting system yet. Dr. Zoe and all the providers can still see your full medical records. They still have access to Epic. It's just your nurses.
So just one more thing I want to mention that I don't want to get a misconception here. As a physician, we do have access to the Epic, but the nursing staff have no access to the access. So when the patient call here, guess what? The nurse is the first one to answer your question. Because physicians are busy, like me, I'm swabbing for the ablation. I cannot answer anybody's question for several hours. So nurse will be first one to pick up phone to answer question. They don't have the access to the, but physicians do have the access. To be fair. Marty,
What do I do? I'm going to Holland and Holland, England, Holland, Rome.
yeah,
What if I have an issue over there?
issue over there? Bring doctor over there too, along with you. Yeah, I'll be happy to go with you. So just so you know, when you have episode of atrial fibrillation, when you travel abroad, make sure you take a blood thinner.
Yeah.
Make sure your heart is not stressed out. Meaning that seriously, you check your pulse. If your pulse not above 100, that means your heart is not stressed out. You don't have to go to the emergency room to pay lots of uninsured cost. That's okay. Just make sure you take blood thinner, you take the medicine as needed to make sure your heart is not stressed out. Sometimes the heart will pop back to normal rhythm by itself. Or if not, come back here. We can deal with it. seriously, it's not dangerous condition.
Are you approved by Network yet?
Anybody can help answer. I don't know. Are we approved for network yet?
I think
Network
I
bill.
talked to Larry, the gentleman who did the welcome, and he did indicate that we're getting a network.
You're getting?
Yes, I don't, he didn't tell me when. He said a lot of these things were gonna come to in the next 1 to 2 weeks.
Good. So be honest with you, we are applying for any insurance company.
Okay.
So the Cedar Care have a limitation. They don't take network, but we say we will. Even though the network patient, we have not get contract from network, but we welcome the patient to be seen here first. Do not charge the patient until we get approval from the network. Then we can reapply that charge.
Well, let's be honest, Oshkosh no longer has cardiology.
Well, they have
I mean,
two. I have two.
You know what I'm saying,
Right, right.
but, you know, most of the cardiology is in the Appleton area.
Right, right.
So, there's gonna be a shift, and there is a shift coming.
Yes, that's a good thing for us.
Well, sure.
So, you know, Oshkosh is not far away from here. It's only 25 minutes drive.
It could be 100 miles away if you don't take.
You know, we got a patient from Charlotte, come all the way,
I understand.
Marinette,
I understand.
an hour away. So,
I understand.
so Oshkosh is not bad. Yes.
I just had a cardioversion done here last week. And prior to that, I called Network Health to check with them to see if I needed prior authorization for having it done here, whatever. But it's good to go, they said, through Network Health.
They can go, right?
Yeah,
No problem, right?
no problem.
So here's the,
$40 copay, that's all I.
so that's the reference for you.
There you are.
So he has network, he
Yep.
come here for medical procedure,
Okay,
no problem.
just got a new patient.
Waiting for you. Good questions?
If you go to my care for your record, when you go into it, on the bottom it says share my record. I think it's a new option they have. What it does is it gives you a code. So if you go see your doctor, like here, so we sit down and medical record, we give the code to the doctor, you can put it into the website and pull up and see all your records.
Oh, that way.
Within 5 minutes.
Oh, really? That way.
Well, I don't know, but within.
So maybe we should let staff know that, you know, when we, but this is your access to your Cedar Care, my Cedar Care. But the minors have no access to your Cedar Care.
Right.
So that's probably the barrier for that. Because you have a right to go to my Cedar Care, but our staff have no right to go to your Cedar Care.
It's pretty much the same information as you get as a patient.
That's right, that's right. Any other questions? That's good. What time is it?
25 after.
Okay, one more question for you.
What's the difference between medical subclinic and heart rate?
Yeah, there's a two different version here. So one is short acting, you take twice a day. The other one is long acting, take once a day. Just the difference between the duration of the drug.
Does it matter what you feel?
I have no preference, just for your convenience. For your convenience. If you say, I either forget medicine, you take it once a day, easier to remember. But if you say, I want to do, you know, whatever Dr. Sir told me, twice a day, that's fine too. I have no preference. Okay, great. Oh, one more question here.
Not a question, but you talked about that book. And some people arrived after that. Maybe you should mention that again.
So that book is called Beat Your AFib. That is a PhD, non-medical doctor, PhD, wrote this book from his own research. Beat Your AFib. The name is Stephen Ryan. R-Y-A-N, Steve Ryan.
Thank you.
Doctor, so you're the best doctor ever, so he's good at switching to because he takes care of the whole thing.
Oh, thank you very much.